stroke in quick response in diagnosis. My aim is that not to show the sequences or what are we are doing it, but there is an aspect which is hidden behind it to respond quickly, and what is the role of the technologist in that management. And two things are happening in this world. One is quick, fast in everything. Only thing is lacking is patient coming to the hospital is very lacking. But after coming here, they want to do it immediately. That is true, one part. But what is our role in this thing is that, because when you consider, we are not doing imaging, we are giving a diagnosis. This is very important, and every technologist to be kept in the mind that we are not giving doing imaging, but giving a diagnosis. This is a very important, and you should keep it in mind. And around 140,000 people die every year because of the stroke. It is a major contribution for the disability and for the economic burden to their families also. We all know that acute stroke can be categorized as ischemic and hemorrhage. We know that ischemic is an infarct where the blood supply is lacking, where the blood vessels get ruptures and spill into the intracranial cavities. We consider as an hemorrhage. It is acute stroke is a medical emergency. It should be a rapid response and the efficient management, where the radiographers or the technologist roles plays a vital role in this aspect. Timely diagnosis treatment is time is brain. Principle emphasizing this is very, very important, and lot of protocols is been adopted by the individual hospitals or the departments about the emergency or handling the stroke patients. But put together, there are some common roles to be played by the technologist in this management. And CT and MR plays a vital role in diagnosing and differentiation between the ischemic and hemorrhage strokes and guiding appropriate therapeutic treatment. And the American Stroke Association and the American Heart Association formed a guidelines how to treat or frame a protocol for the management of the acute stroke. There are some grading, and you have to assess early signs of ischemic stroke on a non-contrast CT scan of the brain, which is very important. It should be done early in the first management to rule out ischemic stroke or hemorrhage. It helps the doctors to evaluate quickly to see the extent of the early changes in the middle cerebral artery territory and decide the treatment like thrombolysis or thrombectomy, which is very, very important, and it has to be taken initially. For that, radiology technologist plays a vital role in diagnosing. We have the signs where you can see the cardiac nucleus, and you can see the putamen, the internal capsular region, and these are the cortical regions. We say this is the frontal, this is the anterior temporal lobe, and this is the posterior temporal lobe, and this is the anterior middle cerebral artery territory, lateral territory, and this is the posterior and the insular cortex. This helps in fast decision making in a stroke treatment. The lower the score, it is very severe, and it is the worst prognosis. And above that 6 suggests eligibility of the thrombolysis and partially thrombectomy, which will be desired by the clinicians or from the interventional radiologists, etc. If it is more than 5, it is high risk of bleeding with aggressive intervention. As we all know that any scan or anything which we do, we should have a deep knowledge of anatomy of that particular study, which is very, very important for that technicians or the technologists to know aware for giving a diagnosis. Then we all know that, I'm just overgoing, we have an anterior cerebral artery, middle cerebral artery, then posterior cerebral artery, where this anastomosis of connecting all this will be called as a circle of Willis, and the blood supply to the brain is subdivided into 2 main categories. One is the anterior circulation and second is the posterior circulation. The anterior cerebral artery is the branch of the internal carotid artery and the anterior middle surface of the brain, mid portion of the frontal lobe, superior mid portion of the parietal lobe, anterior portion of the internal capsular and anterior basal ganglia which is covered or supplied by the anterior cerebral artery. Any lesions to this territory cause the motor and sensor deficit of the lower limb and sensory loss of the lower limb and the urinary incontinence. Second is the middle cerebral artery, is a branch of the middle internal carotid artery, lateral surface of the brain, anterior and lateral portions of the temporal lobes, part of the internal capsular and basal ganglia. Any lesion to this particular territory cause the motor and sensory cortical lesions of the upper limb and face and sensory deficit of the upper limb. We all know that is the third is the posterior circulation, arises from the basilar and posterior inferior surface of the brain, posterior medial and portion of the temporal lobe and occipital lobe responsible of vision, and pica posterior inferior cerebral artery, lateral medulla, vestibular nuclei, inferior cerebral pedicles. And when you see the stroke progress in stages from ischemic to actual infarct. In the artery occlusion, there is densely ischemic central focus and less densely ischemic penumbra, which we have to know, because when the stroke happens, on a sudden it will not become an infarct. It will take some stages for times to become an infarcted area more. Our responsibility is to differentiate between whether the whole thing is being got affected or is there any subacute or acute. It is that for that only we are doing some imaging modalities like CT, MR and interventionals. This is you should be very known and it should know where the culprit is sitting. We have to diagnose that. Cells within the densely ischemic area are usually damaged, irreversible unless reperfusion is quick established. Cells within the penumbra may remain visible, but at the several hours it will not affect. In this image, we are showing here three color. Here is the full infarct area, and the surrounding is called the penumbra, where the blood supply is reduced and it has not become infarcted. On quick response, we can reversible it, and that is the third is called the benign aligma, where the blood supply is reduced. So, to know about this is a blood vessels where the infarct has started, but still the penumbra size is there, blood supply is less here, and it can be reversible. But why, how is this living till now? Because of the collaterals, where the branches, small branches will have the blood supply and will supply to the brain cells here, and it is being getting some small amount of blood vessels where it lives. Initially, as I said, this time is brain. When the patient reaches the hospital and it has been immediately shifted to the diagnostic department and we do a scanning, we see a small area called infarction, and the bigger is called the penumbra, where we can be irreversible by thrombolysis or thrombectomy, etc. When you go little hours back, the infarction is increased, the penumbra size decreases, and it's still further, the infarct area is being increased more, the penumbra size decreases because of the treatment has not started, the culprit is making a big damage to the brain. And when you take a day or later, the infarction increases where we cannot reverse. The imaging the modalities, taking to the imaging modalities, these are the things we do: CT, MR. In that CT, we do a plain CT to rule out any hemorrhage is there or not. And CTA angiography, mostly we do after thrombolysis decided by the clinicians or the treating physician. And the CT perfusion, CT venogram, And in MR, we do a MR brain plane to evaluate the evolving infarct and acute and subacute, etc. We do an MR angiography, and we do an MR perfusion study, and we do the interventional things. In MR, as we said, to look out acute, subacute, and chronic phases of stroke. And to know, we all know that MRA is to see the vascular structures. Because MRA we don't need to, without contrast we can acquire see the vascular structures. And MRP is the tissue perfusion and detect early signs of ischemia. And CT hemorrhage, initial stage, and angiography. Widely, because CT things widely available, can be done quickly, and it will not only help to identify the hemorrhage, a contraindication through thrombolytic therapy, but it also can help detect early stage acute ischemic and depending the features such as the hyperdense vessel sign, the insular ribbon sign, and obstruction of the lentiform nucleus, where the CT scan reveal all this. But this is the three signs are very, very important. Before the patient get out from the table, we have to diagnose, check whether these signs are available or not, because this science is going to help the physician for the treating the stroke patients. This is the stroke protocols. When the patient comes till 24 hours is the basic plane to, and CT angiography is being done after the IV thrombolysis, and in MR we do a diffusion, MRA intracranial and extracranial, and flat sequence, and SWA. No other sequences is required on that particular stage to rule out the acute stroke alone. Additional optional sequences: MRI perfusion, CT perfusion, MR vessel wall imaging, clot morphology, and plaque morphology studies. This we practice on an everyday basis, because a lot of students and technologists are available. This is a routine thing, but my emphasis is that what to be done immediately and what are the response from our technologists to help the patient to get it quickly response or reverse the stroke. Window period, this is a very important, and as per India, this is the very lacking is that window period. Most of the times we may not know the patient had a stroke. They are the self-doctors. Indians are Indians are self-doctors. They will diagnose themselves, they will think themselves, and finally they will come to the hospital. This is a very pathetic thing. But still, now this trend is getting changed slowly, but it is not enough. So we have to educate ourselves or others also to respond very quickly. And from the department also, when the patient is come, they are in each and every organization or hospitals are practicing different types of protocols like stroke protocols, and they are announcing and they are paging, they are giving a WhatsApp message, etc. But whether we are responding it is as the same thing for doing another scan, or we respond immediately for this stroke. We have to work quickly, act quickly, because it is a life saving. Otherwise, you can save the life of the patient, but it will be a vegetable. So it is our responsibility to have more response. Not in some places we heard that there is a practice in the night duty about the technologists. They will say, I will work for 3 hours, you go for sleep. When the cases comes after that, I will do that. But don't do that. Ask for a help in any emergency cases. For acute stroke comes, please activate the whole department, because everybody has a small role in quick response to save the patients. What to look in the first phase of CT? As we said, it is in hemorrhage, hyperacute signs, and score analysis. Any frank hyperintensity, if not sure, do not give report as normal or infarct. Ask for a repeat scan. This is also very important. There, the radiologist role is also there. They are going to help us in many aspects in this. And the we see that in normal, we don't see the width and level of the image like this. We have to do like this and see to diagnose or evaluate the early strokes. This is very important, and as we all know that HULB will be below the 30 and 35. And the signs, what all we are going to see, that is the hypoattenuation sign, which is called the obscuration of the lentiform nucleus, insular cortex ribbon sign, and the hyperdense MCA sign, Sylvian-Fisher dot sign, and the sulcus effacement, loss of gray and white matter differentiation is very important. See, you can see there is a left middle cerebral artery, there is a hypointensity, it is called the hyperdense sign, which indirectly say or say that there is a infarct. There will be a infarct in certain conditions like smokers and hypertension patients. This also will be appearing, but it will be appear as the bilateral. Here you can see the basilar artery is a hyperdense sign, which indicates the infarct. The lentiform nucleus appears hypoattenuated because of the acute ischemic and lenticular territory, resulting in the obstruction of the lentiform nucleus. This feature may be seen on CT images within 2 hours after the onset of the stroke. Where you can see there is the arrow shows where it has been budding behind the lentiform nucleus, where you can see the infarct here. And then here, when you see in the normal things, it is not getting appeared. This is the insular ribbon sign, where you can the Sylvian-Fisher getting refaced, and this is the loss of gray and white matter differentiation. And what are the methods? What are the modalities we use? Is the CT angiography, and what all we do? We take that start from the aortic arch CT angiogram. We start from the arch of aorta to vertex, and we do a triple phase scan. And when we do it, immediately post thrombolysis, we will be doing this to rule out large major vessel occlusion. And the 2 IV lines is needed. That's why I told get help from everybody, because one for the lysis and one for the contrast. What we do in this CT angiogram, we need an 18 kg IV line for lysis and one for CT, and 100 to 120 ml of contrast at the rate of 5 ml per second is used depending upon the scan what you are in the department, and 30 to 40 ml of saline chase from the forearm lines. Pressure injector is always used to have a uniform supply of contrast and saline. And what we look at in the report of the scan, see any vessel occlusion. If it is says yes, see the segment and the site of the occlusions. And third thing is very important to see, that is the collateral signs. This is also very important things, whether it is there or not, we have to see. And you can have a see that collaterals is the branches from the main arteries. You can see the collaterals very well, even though there is a infarct in the middle cerebral artery territory. We have a, because that the cells will be saved because of the good collaterals. And this is the intermediate collaterals, and this is a very poor collaterals. You have to check for this also. This is a very poor collaterals is seen. And why we have to do from the arch of aorta to the vertex? Because you have to see the neck status, whether there is a tandem occlusions of multiple occlusions is there or not, and we have to know whether there is a stenosis here and the toxicity and any dissection is there. You have to find out the everything to rule out. And this is a very important thing. Once the patient is went before, we have to see the maximum intensity projection to see the vessels, how it resolves, where it is feeding, everything we have to see. This is the MIP images. And why we have to include the neck is also because we may not know who is the culprit, where it is sitting. It may be affected in the brain, you have a stroke there, but there will be a stenosis in the vertebral artery or anything, whatever is this. So we have to include arch of aorta to see any aneurysms or any dissections. And pitfalls of the CT angio, we all know that it is a radiation high, renal dysfunction you have to see because of the contrast, low ejection fractions, less sensitivity for the intracranial dissections, cannot determine the flow direction, dynamics or plaque morphology. And CT angiograms sometimes overestimates, so we have to compare with other modalities too. And here you can see some of the cases where the right ICA occlusion and hospital calcification stenosis and ICA top occlusions is also there. You can see some stenosis here. And this is a left CT angiogram, left internal carotid artery total occlusion, proximal MCA occlusions where you can see the post thing. And MRI, what are the essential things we have to see? And most reliable, especially posterior fossa, we have to do DWI. Everybody knows if it is yes, we have to see the score. And the special occasion, rapid diffuse weighted image protocols for uncooperated patients. Sometimes it is very easy, as you all know, that MRI can be put in sagittal, coronal, axial. If we are diffusions in the, especially in the brainstem and medullary things, we can put a coronal or sagittal planes. Minimum 3 mm slices with 0.6 overlap intergraft gap we can take, and some watershed infarcts also can be diagnosis here. And here with this what we have to see here is this is a normal things, but we have to compare with the opposite side. Here is a 55-year-old with 2 hours history of hemiplegia and seizures and vomiting. You can see the Sylvan fissure here, and here it is smallly getting because of the edema, and here you can see the sulcus spacing is getting reinforcement because of the stroke, and you can see the hyperdense lesion here also. And surprisingly, when you do an MRI, there is a huge MCA, fronto MCA territory infarctus here. And after 12 hours, when you do the same patients in CT, we can able to the prognosis of the infarct here. And it is there, watershed infarcts can give small weakness or small limbs things. We have to rule out this is the watershed infarcts. And this is very important. It is like, but it takes some little time, MRA, time of TOF, we can use to see the large vessel occlusions and locations. And contrast enhanced dynamic MRA more useful in detecting the vascular malformation and AV malformation. Pitfalls of MRIs: always overestimate stenosis or occlusion due to saturation by slow and flow of turbulent flow, artifacts in the petrous and cavernous segments and other